Hello, I'm Dr. John Kern from the University of Virginia, Director of Mechanical Circulatory Support and Heart Transplantation there. And I'm here with two colleagues who will introduce themselves in just a moment as we will discuss some issues quite relevant to the field of mechanical circulatory support, implantable LVAD therapy, and heart transplantation.
Hi, I'm Pavan Atluri. I'm one of the cardiac surgeons at the University of Pennsylvania and the Director of Mechanical Circulatory Support and Heart Transplant there as well.
Hello, I'm Frank Pagani from the University of Michigan, cardiac surgeon and head of the transplant and device program at Michigan.
Gentlemen, thank you very much. As we're aware, we're in a very exciting time as it relates to implantable LVADs and mechanical circulatory support. But over the last few years, we've all been dealing with some issues that I think are quite important to us. Let's start off the conversation by talking a little bit about the important topic of RV function or RV dysfunction, particularly as it relates to the patient undergoing LVAD support, and its role in limiting results. What have you fellows done at your institution to deal with this? And let's start off by talking about how you look at these patients preoperatively as you're assessing them for LVAD therapy. Are there any indicators that you look to help decide someone's appropriate for LVAD?
Our experience base is it's actually multifold. I think the two most important pieces of data that we look at are the echocardiogram. Usually we get away with just doing a transthoracic echo. Look at TAPSE or the tricuspid annular motion as well as RV contractility. The one study that I found actually to be even more helpful, though, is a right heart cath and looking at the CVP and the difference between the CVP and the PA diastolic pressures. It seems like whenever you take someone to the operating room with the CVP in either the high teens or the low 20s, you always seem to get burned and need to come off with temporary RV support.
What have you found your rate of temporary RV support to be these days?
Well, I think I just wanted to just mention the things that Pavan said. I think are the two most important things to assess the right ventricle was the echocardiogram and then the hemodynamic assessment, and the combination of those factors are helpful using, and then with the echo using strain also has been shown recently to have been very helpful, regional strain to be helpful. And I think to address that question, John, I think it really depends on what your level of, how critically ill the patients you're accepting into your program and your patient selection. I could have an RV failure rate of 0 if I chose those patients that way, or I can have an RV failure rate of 50 if I was very broad in how I applied mechanical support. So I think it really depends on how carefully you select the patients and what level of risk that you want to have for your patients. I think for the most part, the risk, most programs would say their risk in carefully selected patients are down to single digits, close to 3-4%.
I will say our numbers actually I feel like have gone up in recent days, if that makes any sense. Partly from, I think we're getting a little bit more aggressive as our experience with temporary devices for RV failure has increased. We've had a fairly good success rate in terms of bridging patients, with putting in the long-term permanent continuous flow device on the left side and then a temporary device on the right, leaving it in for a week or 2 weeks to allow the RV to recover, and the patient seem to do well long-term, especially if they came in with sort of an acute on chronic heart failure and had more of an acute RV failure picture. So.
Yeah, we too have enjoyed a very low rate of temporary RV support. We don't have access at our institution to the total artificial heart, and given some of the results about the outcomes of transplant after total artificial heart, I'm not sure I necessarily want to go there. But I think with careful management, and you're right, selection is important, but I'm surprised still sometimes that these patients who are unpredictable. So I think, do you want to talk a little bit about intraoperatively what you do to manage these patients and hopefully sneak them through with, is there anything that people talk about their surgical technique and doing the operation, totally beating and not arresting the heart, and certainly depending on if you have other things you have to do. Let's talk a little bit about RV management intraoperatively.
I think one of the most important things we do is be prepared for RV failure. So you want to be responsive to the setting. So we have, right ventricular support readily available in the operating room, and then you want to carefully manage post-operative medical therapy for your RV support. So we liberally use pulmonary vasodilators such as nitric oxide near routinely in the operating room, and then also some degree of inotropic support, either milrinone or dobutamine. We tend to favor a combination of dobutamine and nitric oxide because it has the potential to be less vasodilating peripherally and then reduces the need for vasoconstrictors peripherally. So those are strategies that might help the RV. Also maintaining we perform the operation warm and beating so that we're not arresting the heart in order to do the operation.
We do the same thing. Do you find any benefit over nitric versus inhaled Flowland?
We actually don't have nitric available at Penn, just given cost issues. So we've got inhaled flow.
That's why I asked, because we have that same problem. But there's, go ahead.
Now, the one thing that we do the same exact thing, but the additional piece that we do is we actually, as soon as you sling up the pericardium, just have the anesthesiologist continue to ventilate with Flowland. I don't know that the data is out there to actually support it, but anecdotally it seems to help us. So we do that.
We started that after one of my anesthesia colleagues spoke with your anesthesiologist, and we have just recently analyzed our data and have found a significantly increased rate of transfusion and blood product requirements when we did that. So we have stopped doing that. We have trouble getting NO as well, but we just try to manage them as you do. And we're pretty liberal with milrinone and not so much dobutamine, and just deal with the vasodilatation with some vaso and things like that.
So do you think that's platelet dysfunction?
Yes.
Between the pump and then the flow in?
I do. Yeah.
I mean, one of the other options, too, to consider to protect the right heart is a balloon pump perioperatively, because I think if you have a complicated redo, having a balloon pump in place and giving you that extra hemodynamic support during the dissection and making sure you're not hypotensive, again, is a strategy to protect the RV and from intraoperative injury. So.
I agree. Let's move on and talk a little bit about, there's been a little bit of a concern recently over what looks to be an increasing pump thrombosis rate, and perhaps that leading to some secondary events such as stroke. And what are your guys' thoughts on that? And has this altered at all your anticoagulation management? And when you have someone coming in who is in that gray zone, like they always seem to be, what makes you pull the trigger to try some other therapy, such as lytic therapy, if anyone ever does that anymore, or pump exchange?
Well, that's a topic that could probably take up 3 hours. I think there's a couple points that probably make. I mean, device thrombosis has been with us for a long time, and many pumps have shown the propensity for that. And I think the reasons why we're seeing this uptick are very difficult to understand, and probably are related to a lot of different factors. Some of them may be related to the pump, specifically to the pump. Some of them may be related to the differences in our practices. I think that if you look historically, what had happened is early on with our pump experience, we were reacting to a lot of bleeding events. We got more conservative in terms of the lower INR goals, and I think some of that may reflect what we're seeing with the increased pump thrombosis. And now I think more people are going back to more aggressive anticoagulation protocols. What the result is, we're likely to probably see some more bleeding events, but I think the trade-off might be more appropriate. In terms of the therapy, I think it's a real important point to mention that the type of thrombus we see amongst different pumps is related to different reasons, and one therapy may be good. So lytic therapy may be good for one type of thrombus and one type of pump, but may not be effective for a different type of pump thrombus. So I think understanding the pathology of the thrombus is important.
Have you tried lytic therapy? Because we certainly don't do lytic therapy. We'll do the antiplatelet agents when someone comes in. It usually is the first line, as long as they've got hemodynamic stability, and all we're dealing with is like an elevated LDH and evidence of power spikes or whatnot.
I think the one thing we can say about lytic therapy is it is very good at getting rid of the clot from the pump. Where that clot goes then, and the other effects. So we've done it just twice, ultimately with less than ideal clinical outcomes. So I would say lytic therapy is probably not In at least for a certain point, you're right.
Right.
hear what
I
you're
think
saying.
if you talk about the HeartMate 2,
Right.
the pathology there, I believe, I think as best we understand, is that there's fibrin deposition, and so that's not a thrombus. And then there may be acute thrombus on top of that, but lytic therapy is not likely to be successful in that setting because of its pannus at that point and denatured protein from the heat from the bearing. So I agree with you. I don't think lytic therapy is appropriate for that setting.
Have you had any success with antiplatelet agents? Because we try it on our patients, and it seems like we're taking the pump out a week later anyways.
When are you trying it? What's the trigger to add that, or are you adding it routinely?
We usually add it in one of two scenarios. One, they show up, routine lab draw, they've got an elevated LDH.
Right.
Second, they show up, they've got issues with the pump, so whether it's a power spike, drops in the RPM, but some hemodynamic issue with the pump. And as long as they look okay, there's no evidence of shock, then we'll try it. And I don't think we've ever gotten it actually to be of benefit for us.
It's really hard to understand the data because everybody uses sort of a different cocktail, and I think it would be very helpful for the field if, that some type of uniform strategy could be developed, and then based on those data, then we could make changes to see how effective. But I think it is, at the present we have no understanding how to treat it because everybody does something a little bit different. We really don't know how effective these strategies could be.
Yeah, I agree with Frank. I think there's just so much variability out there. We can all probably point to some success with, altering this and that. When we see a little bit of an increased LDH, but they're doing okay, we will make sure their INR has been okay. But if that's been fine, then what we'll do is bring them off their Coumadin, and we'll try something different like Lovenox. And we've actually had some modest success with Lovenox therapy and seeing LDHs come from that 700 or whatever it is, elevate it back down to a tolerable range. But everything else is a little tricky as it comes to these patients who are waiting transplant, and then they've got other agents on board. We've not had any kind of reproducible success with Plavix or any other, antiplatelet therapy. Yeah. Pump exchange is a pretty straightforward thing too. So I think sometimes we shy away from that, or our cardiology colleagues may shy away from that. But I think that's becoming a straightforward thing.
Yeah, we've actually, unfortunately, are gaining a fair amount of experience with it. It seems like most centers, I think we did.
I think at least some of the pump replacement strategies now we use less. You can avoid a sternotomy if you position the pump. If you think about future reoperations, you can position the pump at the time of initial implant in such a way that it makes it readily accessible through a subcostal incision, so that some of the devices don't necessarily require a sternotomy to go back on and replace the pump, which is a benefit.
How about your de-airing strategy? I'm always curious about it because I've been putting up the endoaortic balloon, just from the minimally, sort of a transference for a minimally invasive. And
At the time of exchange.
At the time, so I put the 22 French cannula with the arm on it and put the endo balloon up, and I've got a great vent that I use to come off on my mini mitrals with. Oftentimes there's no air, though. You come off, and there's really very little air when you come off.
Yeah. I always do my best to, sometimes it's a struggle, and we can do most of it through a subcostal. I sometimes end up needing to make a little partial sternotomy. Or if the outflow graft is over to the right side, I'll do a small intercostal incision and get the graft out and put a DLP in there. Because I do like to have something to de-air, but I don't have an endoaortic balloon with a vent that readily available. So I always try to get something in that way.
And to do it subcostal, we usually have enough control of the distal portion or the proximal portion of the outflow graft that we're able to get a needle in there, proximal to the clamp.
As long as you leave, at least when you're talking about the HeartMate 2, if you leave that outer bend relief in place, the graft just pulls straight out. So
it does, but don't pull too hard. Let's move on to the next topic, and it's there seems to be a changing profile, if you will, for patients undergoing VAD therapy, particularly as it relates to their INTERMACS score. And I think with more and more VADs being put in by newer centers, we're seeing probably less INTERMACS 2-3, probably more INTERMACS 4 or 5. But that's still that INTERMACS 1 patient, the patient who comes in totally unexpected, crashing and burning, whether it be the young patient with a viral issue or an older patient with a sudden catastrophic coronary event. What are you gentlemen doing to temporize those folks to see if they are a candidate for a long-term VAD?
We use one of two strategies. We've gotten away from using. Sort of developed the dogma of a HeartMate 2 or HeartWare, long-term devices are not implanted emergently. That being said, so our two strategies really are to either use ECMO or biventricular temporary support as needed.
And so your ECMO, tell me about your ECMO. How are you hooking them up? Depend on the situation.
So in terms of,
well, are you just
cannulation strategy?
Yes.
So basically, our cannulation strategy is almost always an SVC drain from above, put a cannula in from the groin to try maximizing drainage, femoral arterial cannula and an SFA cannula. We try doing everything percutaneously to just minimize bleeding complications, stabilize them, get them over the shock, get their LFTs to reverse, renal function reverse. It also, at that point, gives us time to sort out social issues, transplant candidacy, if age appropriate, medical compliance issues, and then determine really which the best path is. Is it rarely we'll list them for transplant, try going straight to transplant from ECMO, bridge the transplant VAD, or just a DT VAD.
We've not enjoyed quite the success that we would like with full ECMO support, so we try to get by with a little less than that. And whether that be a Centramag or something, but mostly what we use at our hospital is tandem heart. These folks come into our cardiology service, and we've had a fairly significant number of patients who have been bridged from their acute catastrophic event with tandem heart, and we sort out all those issues, and then we go ahead and take them down and put an LVAD in.
I think both those strategies, work. I think the nice thing about applying the tandem heart or other percutaneous approaches, such as the Impella, is if they provide an adequate degree of support, because you can readily change those systems over to an ECMO system, and then the nice thing is that you have some degree of LV venting in place already. So either with the tandem heart, that the left atrial catheter now becomes a pulmonary draining the pulmonary venous system, and then the Impella can still vent or unload the left ventricle in the setting of ECMO. So I think you can't go wrong by starting off with one of those devices, and then if you made the error and underestimating the amount of support, then you still have ECMO as a backup.
Yeah, I think that's a good idea. We've not, the Impella just doesn't seem to have done it quite for us, but I like what you're talking about with it in that situation. That sounds nice. And the tandem heart's great. The only thing about it, obviously, is the patient is incredibly immobile with the tandem heart in, and sometimes they are in the ICU for quite a while before they make it down. But the conduct of that operation is straightforward with the cannulas that are already in place.
But I think I want to emphasize the point. If you really go back and read the true definition of an INTERMACS 1 patient, that is someone in really obvious cardiogenic shock, and by description, there's significant organ injury present, and so that clearly is not the patient you want to take down and put an implantable pump in. So
absolutely.
I think early days we were pretty aggressive with getting those devices in. You'd put a lot of BiVADs in patients when they were crashing and burning, and we look back at our data, and we're actually a little horrified by the numbers. It was, basically adding the stress of a major surgery on top of end organ dysfunction never ended well.
Right. No, that's why I think these new temporary percutaneous devices are so good in that situation, because it really can reverse those things and allow you to sort things out.
I will say I've loved using the tandem heart in the past. They pulled it off our shelves for cost issues, really. And our cardiologists weren't as willing to put the devices in. And so we had a hard time finding sort of a partner in cardiology that was willing to put them in. So
we have a couple of cardiologists who are very adept at putting them in. In fact, we've actually used the tandem heart for RV support in a few patients. And one of them was an LVAD patient, but a few other just post-cardiotomy patients, and that works well too.
I think both the Impella and tandem work really, really well.
Are you saying Impella? Are you talking about the 2.5 or the surgical 5?
Right. I don't think 2.5 for patient cardiogenic offers
right.
an adequate support.
That's one thing that we've seen is we've had a lot of patients that'll get transferred in from other hospitals where they've been on the 2.5 and they're literally it's a false sense of security because they've been in shock. You're just exacerbating the situation, and it gives them a sense that the patient's doing okay, but at the end of the day, they're in shock for a longer period of time.
I agree. Well, gentlemen, what do you think, as we wrap this up, what do you think is the most exciting thing out there on the horizon? Is it doing away with the driveline? Is it smart VADs? Or what do you think we can look forward to?
Well, there's a nice symposium this morning, and I think certain themes came through, and I think the devices are getting smaller. The concept of partial support devices, minimally lower, rather should say less invasive approaches, miniaturization. And I think it also emphasized that with the smaller devices that maybe perhaps some unique biventricular support applications will come about. So I think the future looks pretty exciting.
I think the two most exciting pieces are the biventricular support, long-term, and then totally implantable.
Right.
The issues with all the driveline infections can finally disappear. And then finally, patients, it's a much easier sell to a patient who may be an INTERMACS 3 or even better, a 4 or 5, who are really the patients that would benefit long-term from it.
Yeah.
Always we have to, new technology brings new challenges.
Agreed. Well, any final comments? Gentlemen, thanks for taking the time today. Appreciate it. Very good.
That was a lot of fun.